coronary primary prevention trial, which illustrated, was one of the first studies to show a relationship between lowering serum cholesterol levels and mortality, and there the correlation between adherence and outcomes was very, very tight. So I think that indirectly from any number of clinical trials, we do see a correlation. So we can have confidence that even though adherence becomes only a surrogate measure, but we can have confidence that adherence does matter.
Thank you. We have time for one more quick question. Unless, did you have a comment? Go ahead.
Can I just briefly comment to your question? So there's lots of interventions that are out there, a lot of quality improvement interventions that are under the radar. Because they're not published in a scientific journal, they don't get a lot of press. If the institution themselves is not, providing a newsletter or they're presenting any of their findings, then we don't know about it. But many of these interventions, what you really actually bring up is a good point that financial motivation, incentives, people have to be paid for their time to be able to do these interventions. And even patients, there's actually a lot of studies that have actually been published showing that if you actually pay patients to adhere to their medications, pay patients to stick with programs financially, that improves their adherence. So incentives is actually being looked at heavily. And in the technology world, they're trying to use gaming as a way to engage and motivate and keep people adhering to the app or adhering to medications. But financial incentives are key.
Thank you. We are actually out of time. So thank you for your questions. And the panel will be here for a while yet, so please feel free to ask them questions. So welcome back. And for the rest of the morning, we're going to be focusing on health disparities. But before we get started, I did have a couple questions about slides. All these slides will be available on our website. What we'll be doing a few weeks after this conference is we'll be mailing all of you a link. You'll be able to have access to all the conference information, including the slides. And so feel free to access that. That's really what this conference is about. So as I said, we're going to be focusing on health disparities for the rest of the morning, and we have two speakers, and we'll be hearing from them from their unique perspective, and we will have time for Q&A after both are done speaking. So our first speaker is Joan Werblund, who is Vice Chair and of the Board of Directors of the California Health Collaborative, which is a nonprofit administrating programs throughout California to promote quality life and healthcare for underserved populations. Joan has also worked as a diabetes nurse specialist for more than 30 years. So welcome, Joan.
Good morning. I'm the entertainment. There are no slides and no statistics. So grab your coffee cups and relax. When I was asked to speak this morning, and Elaine said, well, just talk about your experiences, your successes, and what works and what doesn't. I said, well, successes, I can do that in about 3 minutes. The failures are a whole conference. We'd spend all day talking about things that didn't work. I've been doing diabetes education expressly for 37 years at UCD, teaching the patient, their family, nurses, doctors, second-year medical students, and first-year internal medicine residents. So I've covered the full gamut. What I want to share with you today are some of the experiences I've had in the areas outside of these studies, in the area between you and the patient and what's out there. The first program that I got involved with was I was asked to join a state team. And we were shuttled up and down the state visiting Indian reservations, looking at Native Americans and diabetes. And it was interesting. We were able to establish some parameters, and we were to teach the people who went into the homes. Not a whole lot came of that. That was back in the early 80s. It was an interesting trip through California, but I don't know that we really accomplished a lot at that point. The next program that I was involved with shortly after that was I was asked by Governor Wilson to head up a committee. California had just been awarded, we were the third state to get NIH funding. With the goal from NIH was that each state would have a diabetes program. that would look at diabetes management in the state. That was a very awesome task, trying to get two physicians in the same room to agree on what was the standard of care, and then I brought in pharmacists, nutritionists, nurses. It took us 4 years to put that program together to battle it out. But we came up with a program which is now the Diabetes Coalition of California, and it is an ongoing program. We were the first state to have what we called guidelines as opposed to standards. Standards seem to have a litigious tenure to them. You can be sued or taken to heavy task if you don't follow standards. Guidelines were meant to be incorporated, and we were the first state that actually had all of our major healthcare providers, the Health Net, the Blues, all of them, to take these guidelines and incorporate them into their patient population in a way that it suited them best. So that was, that I considered a success in my previous life. Shortly after that, I was invited to go to Africa. And I spent a month with a health team in Africa looking at diabetes. There's a lot of diabetes in Africa. Very, very interesting. I didn't see any type 1s. They were all type 2. And I don't think, other than the chiefs of the various villages that we went in, there were no overweight people. They were all lean, and for me that was a different experience in dealing with type 2s. We set up programs for diabetes, and what is interesting, as I was looking through, we have a lot of information about barriers, but I have yet to see in any book or anybody's recommendations what to do with the barriers of a disruptive government. We were in Nigeria. Every other person has some sort of a military uniform on, and they all have AK rifles and bullets across their chest. That's a big barrier, and they weren't really happy to have us there. And the biggest barrier I had to deal with were the witches and the witch doctors, who really didn't want us there. And some of the villages that we were in, they would stand outside the buildings, which were just vacant buildings, no windows, no doors, just cabins. And we would be seeing patients, and they would be outside the windows mumbling and letting us know that they were there. And one of the successes we were able to make was that the women could take the babies to Juju. And that was okay with us as long as after their appointment, and Juju was done by the witch doctor and the witches, they would bring the baby back to us so we could see. Sometimes they would have had what's referred to as the coining. They do something similar to that. We would have see on their abdomens and all scars where they had done these scratching mechanisms. They don't cut them with a knife, but it's equally as scarring. And the babies would come back with all sorts of bands around their arms. Sometimes they were tied very tightly. And this was all based on what they thought was wrong with the baby. So we had to deal with that, but we were successful in implementing a lot of diabetes interventions, particularly in the rural clinics, but I've yet to see those barriers listed in anything I've ever read, but they're real. My next project, and the one I'm going to really talk to you about today, shortly after I retired from the university, I received a phone call saying that a grant that I had applied for and hadn't heard anything about, I had been given. So went my first year of retirement. The grant was from the American Pharmacists Association Foundation. It was part of the Project Impact. And at that point, they had done the 10-city studies. They had done a lot of work on the East Coast and into rural areas of Ohio, and I come from Pennsylvania, so I know what rural there means. And I had written the grant saying that I wanted to work with the migrant farm laborers in the rural areas of Southern California. So no one else had applied for anything. One other grant was given in California, and it was in the rural area of Santa Barbara, which I've yet to figure out where that is. I have not seen it yet, but there's a rural area somewhere in the area of Santa Barbara. So I was given the grant and went down to, and I don't know how many of you are familiar, take the trip down I-5. And in about 400 miles, there's a truck stop and you make a sharp right and you're headed into an area called Lost Hills, appropriately named. I went down there with one of our staffers from California Health Collaborative, and Jessica has a master's in Spanish, and she's from Guatemala originally. She has a master's in Spanish and a master's in social work, and we sent her to Promotora School in Southern California. So she came back with some skills of working with the community. So we set out for the hills. Now, when you talk about barriers, we most frequently will talk about the barriers that between the patient and us. Let me tell you, the barriers that we experienced, we were not allowed to go on to certain farm areas. They didn't want us talking to the employees. We were forbidden from giving out too much information. I was asked to leave one meeting because a patient asked about whether or not they were eligible for Medi-Cal, and I said I would help them find out. And they said, "You have no right to talk to our clients. That's not what you're here for." So we fired them and we moved on to another ranch. We ended up with a work staff of 700 migrant immigrants. 500 of them volunteered to work with us. About a third of those had diabetes, had not been diagnosed, had no physician of record. So we decided that we had to do some screening. So we did the hemoglobin A1Cs, the finger sticks. We were doing them day and night because when they are processing, we were on the world's largest pistachio farm. I know you've seen them on television. And they worked 24/7 when I call it the peanut farm, when the pistachios were being processed. So we would be there at 3 in the morning when they had a break. We'd be there at midnight. Whatever time they had time, we would be there. And we did hemoglobin A1Cs. We had set, 7.99% as you would rule into our project. Well, most of our hemoglobin A1Cs were 10, 12, 14, 15. I didn't know they could go that high. So we had to redesign again. So we ended up with about 100. And then we set out to educate. And what we found was we were running probably the country's biggest Tupperware party. For classes, we gave outdoor prizes every class, and most times it was things from the dollar store. We would put them together in gift packages. When we talked about foot care, we had foot creams, we had vials, we had all sorts of things for foot care. I can tell you, of the people who ruled in, who stayed with us, none of them left. They came every week. And it wasn't easy. Some of them didn't have transportation. So we had to do our classes at shift changes, 4 in the afternoon, 4 in the morning. Whatever time they could get off and come to us, we would do the classes. They didn't speak English. I don't speak Spanish. By the end of the program, I could speak some Spanish. That was the promise they made me. They would stick with the program and I would learn to speak some Spanish. All of what this boils down to, we were there for a year, and I spent a lot of time living at the truck stop, Motel 6. It's nice if any of you are down there. It was me and the truckers, and we worked. We did the classes, but we did things like in the cafeteria, we removed the French fryer. We brought in multigrain tortillas. We made up a price list. The most expensive foods on the menu that nobody really wanted to pay the money for were the least healthy. The healthy foods were down in the $1 lunches, the $2 lunches that everybody could afford. We brought in trucks from Bakersfield of fruits and vegetables. All of a sudden, we had people going home with bags of fresh fruit and vegetables. There was no hospital, no physician's offices. We couldn't mail order medications for them because they don't have a street address and you can't send meds to a P.O. box. So we had to make a contract with a pharmacist 2 hours away to once a week make a pill run so we could get them out. These are all the barriers that we dealt with, that we consider barriers for our participants. It's their way of life. But we had adherence. By the time we left, we had everybody's hemoglobin A1C down to 10 and under. We had exercise classes. The ladies had formed a walking group at night because there was a soccer field there, and the owner of the company lighted it at night so they could walk. So when you talk about, positive experiences, this was really very positive. We learned a lot, but it's building trust. They didn't trust me. They thought I was the long arm of the law, that I was going to have them deported. It took a while to build up that trust. Family support. Most of them said their families didn't want to hear about their diabetes. They didn't want to change their diet. So we had to deal with those issues. A lot of depression. And if you can't get these things out with your motivational interviews, with all of the tools that have been adapted, it's very difficult. It's not easy. But there are successes. But the patient has to believe, that you're interested. And I'm sure this is nothing new to all of you. And our real savior were our pharmacists who came on the team. They did the adjusting. We put people on insulin, we put people on pills, and they maintained the management. The patients love them. They trust the pharmacists. They don't see them as an authority figure. They're used to dealing with pharmacists in their own countries. And you'll find this in a lot of your populations. You don't have to go down to Southern California and live in the fields with a hard hat for a year like I did. You will find this in your own practices. And I think, if you get back to the basics is what I guess my bottom message is. That's where the successes are. That's sort of my life in a nutshell.
Thank you. Thank you, Joan. All about getting back to the basics. Yeah, thank you. It was really helpful to hear your stories and practical experiences as well.